Hey everyone, this is Mrs. Van Buskirk, and today we're going to be talking about the endocrine system. The hypothalamus is kind of the main gatekeeper or the pilot light for the body. Kind of keeps everything going, and all the signals go through the hypothalamus to all of the different hormone glands. It's really kind of cool how the whole thing works. It's pretty miraculous. So we're going to study a little bit about the endocrine system and each of the organs that are involved. Now remember, when you talk about the endocrine system and the disease processes that are involved, what you really want to focus on is if this patient has this disorder, what am I going to do for the patient? Remember that the A&P involved is all very cool. Yes, you have to know the basics of A&P, but really what you need to know is the nursing care involved. So make sure as you're studying that that's what you're focusing on. The endocrine system contains organs including the testes and the ovaries, the pancreas, the thyroid gland and the parathyroid glands, the pituitary gland, the pineal glands and the hypothalamus, the adrenal glands and the kidneys. And if I gave you a little overview of what each of these are, you probably know more about the endocrine system than you think you do. As I said before, the hypothalamus is kind of the gatekeeper or the pilot light for the body. Pretty much everything comes from the hypothalamus, at least the impulse for other glands to work. If you look at the hypothalamus and everything that it puts out, you can see that it does thyroid hormone, dopamine, growth hormone, somatostatin, gonadotropin, oxytocin, vasopressin. Those all come from the hypothalamus, and those are all the ones that regulate most of the other hormones. Over here in the pineal gland, the main hormone that's secreted is melatonin. Who knows what melatonin does? You're right. It helps you sleep. I heard you guys through my voice. Growth hormone comes from the pituitary gland, but you can see growth hormone releasing hormone comes from the hypothalamus, then it tells the pituitary gland to put out the growth hormone. So again, hypothalamus kind of regulates the start of it, and then the pituitary gland sends a signal to do the rest. And most of the hormone system works the same way. When you're talking about when you're talking about hormones, think about neurotransmitters. You can think about how each hormone is secreted in response to a stimulus, and that helps regulate all of our body functions. Information about the hormone levels within each one really do help the hormones move around, and each circulating hormone exerts its effects on certain target organs or tissues that have receptors for the hormones. There's also a negative feedback mechanism, which is like if a hormone is circling around, it decreases the amount of the original hormone that it secreted. I know that sounds kind of crazy, and don't focus a lot on that. But if a gland is not regulated effectively, the rate of secretion of a hormone becomes abnormal. And when that happens, there's quite often a negative feedback mechanism. In other words, then the gland completely stops or continues to spit out way too much. So we don't want to have anything happen that would stimulate the negative feedback system. The first thing we're going to talk about is diabetes insipidus, and then we're going to talk about the syndrome of inappropriate antidiuretic hormone. If I were you studying these two disease processes, I would make a chart. You know how I am about charts. I would put diabetes insipidus on the left-hand column, and then I would put syndrome of inappropriate antidiuretic hormone on the right-hand column, and you'll start to see similarities and differences between the two disease processes. So let's look at the pituitary gland. It hangs off of the hypothalamus. It's like a little stalk. It has 3 lobes. The anterior pituitary gland controls growth hormone, prolactin, ACTH, thyroid stimulating hormone, follicle stimulating hormone, and luteinizing hormone. The posterior controls the secretion of antidiuretic hormone and oxytocin. Antidiuretic hormone, as you can probably guess by the word, has to do with fluid regulation, and oxytocin, as you know, has to do with maternal contractions. It's the mothering hormone. And then the middle lobe of the pituitary gland is the melatonin stimulating hormone. We're not going to cover all these again, but we are going to focus on antidiuretic hormone. It has a very, very, very important function. It regulates the fluid in our body. It helps control blood pressure, again, by regulating the fluid. It helps us conserve water when we need to and pass water when we need to. So if antidiuretic hormone is whacked out, we're going to have too much water, too little water. When antidiuretic hormone is increased, the absorption of water, we have an increased bodily absorption of water and decreased urine output. So to maintain fluid volume, you have to have a balance of both, and that helps us maintain the blood pressure. When there is a deficiency in ADHD, listen to me, antidiuretic hormone, it's usually caused by injury or assault to the pituitary gland. So this can be caused by tumors, abscesses, meningitis or an infection, a severe head injury. Certain medications can cause this to happen, and then significant kidney damage can also threaten the regulation of antidiuretic hormone. When there is little to no ADH, there is no signal for the kidney to hold on to fluid. So if you're doing a chart, you want to write on the left-hand side, little or no ADH. That means the kidneys don't know what to do, so they just let all the fluid out. And the patient will have huge amounts of urine, and the kidneys just can't concentrate the urine. Now, when I say huge amounts of urine, I'm talking copious amounts, 15 to 20 liters of urine a day. They'll be excessively thirsty, very, very weak, dehydrated, they'll have weight loss, and what you need to know, if you have diabetes insipidus, by the way, this has nothing to do with blood sugar, if that's getting you confused already, there is low sodium in the urine, okay? And the reason why, again, it's whacked out, because the sodium is diluted by the intense amount of fluid. But because all of the fluid is being sucked out of the vascular bed, the sodium in the vascular bed is staying high. So think about it this way. If you had a river, and at the bottom of the river, let's consider the water in the river to be our blood and the fluid in our blood. Okay, so that's the water. And at the bottom of the river are all these rocks, and the rocks are the sodium. And then you open up a dam, and all the water is let to come out. You're going to see the rocks. All that's going to be left are the rocks that are sitting at the bottom. So if you can try and think about it that way, maybe that will help. Because the patient has lost all of their fluid volume, again, remember, things are out of whack. They'll have poor skin turgor, they'll be dehydrated, their sodium content in their blood vessels will be outrageously high. So again, we have to make sure we care for that patient so they don't go into shock. They'll go into shock because if they are dehydrated and they don't have appropriate volume, their blood pressure is going to go too low. So what are we going to do for them for that? Here's how we're going to manage it medically. Okay, this is the doctor's job. First of all, they're going to give synthetic antidiuretic hormone. That comes in the form of desmopressin or lipressin, vasopressin. And by the way, desmopressin is used as a nasal spray quite often in children for children who wet their bed. It's found to be very, very effective to stop bedwetting in children who are too old to be wetting their bed. If you use a synthetic ADH, it works pretty well. Vasopressin is usually used only in emergency use. And if they have nephrogenic, so diabetes insipidus that's caused by kidney damage, the treatment would be a little bit different. So, what are our nursing diagnoses? Of course, it's deficient fluid volume related to compromised regulatory system. So if you have deficient fluid volume as your nursing diagnosis, what is your treatment going to be? Well, we're going to give them a lot of fluid, usually PO or IV fluid. We're going to monitor for all the signs of dehydration. Strict I&O, and we have to do patient education. If you are looking at a patient who is dehydrated, what is your number one concern? The number one concern is to keep their blood pressure high. And I'm not talking high, but keep their blood pressure normal. You don't want it to go low. If they're exhausted from continually urinating, even though we're not in big support of Foley's, sometimes they have to have a catheter until this passes, just for their own comfort and their ability to rest. You're going to be weighing these patients every day. And again, think about the simple things. When we weigh a patient every day, what are the rules? The rules are we weigh them in the same clothing at about the same time of the day. If it's a bed scale that you're using, you want to make sure that you've removed all the blankets. So again, you have an equal weight each day. Evaluating your nursing care, no signs of dehydration. You want to remedy that continual thirst. You want to keep their blood pressure up. You want to make sure their skin turgor has returned. All of those things that, again, pick a nursing diagnosis and let that be your guide as to how you're going to provide the care. The next thing we're going to talk about is the syndrome of inappropriate antidiuretic hormone, and I'm going to put that into the next video. Talk to you soon.